that is hydatid cyst of the liver. Now, before I enter into the topic proper, can you name this organism which is causing hydatid cyst? Yes. What is the name of the organism?
Sir,
Echinococcus
it is
granulosus.
Sir, Echinococcus granulosa.
Echinococcus granulosus. Very good.
Yes,
Echinococcus
sir.
granulosus. Now
Yes,
it
sir.
belongs to which classification? Yes.
Dog tapeworm parasites.
Birds.
Dog tapeworm. Very good. It belongs to the parasite family. Yes, of course. Then it belongs to the metazoa family, and under that metazoa, it belongs to the tapeworm. So it's a type of
It is
tapeworm actually.
it's-
Exactly. Dog tapeworm. Okay. Echinococcus granulosus. Let's enter into the topic now. All of you, please pay attention. The disease, which is known as hydatid cyst of the liver, is caused by Echinococcus granulosus. This is the name of the organism, which is transmitted by dog, which are the chief mediator, or they are known as definitive host in this case. And man is the intermediate host. Okay, man is the accidental intermediate host. So remember, this is the life cycle of these parasite. They have a different type of host. Definitive host means where the sexual life cycle occurs, and intermediate host is the another type of host. After swallowing the ova, they penetrate the gastric mucosa, they reach the retroperitoneal structure, and then they penetrate the portal vein, and then they enter into the liver. Okay, they enter into the liver. Now, having reached the liver, the organism grow and develop their own protective layer and form hydatid cyst. Okay, so this is what is happening inside the liver because of these organism. Now, let me clarify this once again with the help of another picture. Now, see here, all of you, please pay attention. So this dog is the chief, or definitive host of this Echinococcus granulosus. That's why it is also known as dog tapeworm. Liver is the main organ which is involved here. Okay, this dog, after consuming this, cyst which is present in this, organ or meat, you can say, the dog is consuming this, so it will enter into the dog's GI tract, and then it will develop into the ova. It will develop into the adult form, and then the adult form will liberate the ova. The ova are expelled, okay, on the stool or the environment, you can say. Now, accidentally, if we, ingest the particular food or the drinks which are contaminated by this ova, then we can get the infection. And similarly, sheep and other cattle, they can also get the infection by ingesting that contaminated stool. Okay, so this is the way. And then again, they are also infected, and the dog can get this type of larva by ingesting the meat. So this is how the life cycle will continue. So man is definitely the accidental type of host here. Now, what happens inside the liver? Okay, what this Echinococcus granulosus is doing inside the liver? Now, see here, this is quite interesting. These are the layers of the hydatid cyst, okay, in the liver. The outer layer is called the adventitia, or also known as pseudocyst. Okay, the middle one is called the ectocyst, or the laminated membrane, and the inner one is called the endocyst, or germinal epithelium. Now let's clarify about this so that it will be easy for us to understand the topic. The adventitia or the pseudocyst is the fibrous layer which is actually derived from the liver tissue of the host. For example, if human are infected, then this fibrous layer is derived from the liver of human being. Okay, our liver will contribute the formation of this fibrous layer. It is the reaction of the liver to the parasite. It is adherent to the liver and cannot be separated, so also known as pericyst. And during the removal of this hydatid cyst by surgery, it is difficult to remove this layer also. Usually the surgeon left it behind because of the difficulty to removal. The middle one is the laminated membrane or the ectocyst. It is white and elastic, and it is produced by the endocyst. So this endocyst or the germinal epithelium is responsible for the formation of this laminated membrane. Now, it can be easily peeled off at surgery, and it has to be peeled off or it has to be removed. The inner one is germinal epithelium, is the innermost layer. It secretes the hydatid fluid inside and ectocyst outside. And inside this fluid, the scoliosis of Echinococcus granulosus can develop. Now, I'm talking about the different layers of the hydatid cyst here. The outermost layer is called pseudocyst, middle layer is ecto or the laminated membrane, and the inner one is the germinal epithelium or the endocyst. This endocyst is the most important layer of this hydatid cyst actually, because it is the active one. It secretes hydatid fluid and ectocyst outside, and within this hydatid fluid there are scoliosis of Echinococcus granulosus present. This scoliosis develop into the adult Echinococcus granulosus later on after they are eaten by the host. So they are very active component of the hydatid cyst. Now, few more important point here. This hydatid fluid is highly allergic fluid, extremely allergic fluid in that sense. During surgery, somehow, if the surgeon spills this hydatid fluid into the peritoneal cavity, then the patient may get anaphylactic reaction. Number one. Number two, if some fluid is spilled and it is left behind, other hydatid cyst may grow or may form in that area. So the surgeon has to be, very careful while during the surgery, not to do this type of things, and they are very vigilant actually. Okay, let's talk about the clinical features now. Hydatid cysts can be silent without any symptom throughout the life. Okay, it depends how big is the cyst and where exactly is the cyst. If the cyst is not giving compression to any nearby structure or is not causing any jaundice or things like that, then it can be silent. Sometimes it is discovered accidentally on routine examination. For example, the patient has gone to the hospital for routine health checkup, and ultrasound these days is a part of routine health checkup. So ultrasound was done and that ultrasound has detected hydatid cyst. So it can happen. Some other type of clinical feature would be dragging pain in the upper quadrant of the abdomen due to hepatomegaly. Yes, liver will be enlarged because the cyst must commonly develop inside the liver. And as a result of that, the Gleason capsule will be stretched and there will be dragging pain. When we examine that liver, we feel a smooth surface, and this is non-tender mass. There is no inflammation. Remember, it is not abscess. There is nothing like infection or inflammation going on there. Typical hydatid thrill can be present on rare occasion. This hydatid thrill, it is just like eliciting fluid thrill in case of ascites. Now, I'm sure you have studied about fluid thrill test. Ascites can be diagnosed by different type of tests like shifting dullness, fluid thrill, and puddle sign. Okay, these are the three important ones. Now we can compare that fluid thrill with hydatid thrill. Now see there, hydatid thrill is demonstrated by a three-finger method. Keep three fingers over the liver, focus over the middle finger, and get the impulse by other two finger. Okay, so this is known as fluid thrill. It is not detected in all type of hydatid cyst. It is only detected in a big hydatid cyst and a really a superficial one. Patient may present as an emergency with severe abdominal pain following minor trauma. Okay. This can rupture even after minor trauma. And patient may present with anaphylactic shock, okay, if it ruptures. Sometimes, even without any intake of the drug. Now, listen, this type of cases can happen. Even without any intake of the drug, without intake of any food, without going to any new places, something like that, people may get severe type of allergic reaction or manifestation, a bit like anaphylactic reaction. Who knows? This may be caused by hydatid cyst, which is developing inside the patient. So we should not ignore this type of cases. A good investigation has to be done. Now, what investigation we like to do in this case? Ultrasonography, definitely, it can detect the cyst, localize the cyst, and is used for aspiration purpose as well. But this aspiration may be dangerous. If we spill the fluid inside, patient may get anaphylactic shock. So we should be careful. Another is plain X-ray abdomen. It may demonstrate speckled calcification in the cyst area, okay, in a chronic type of case. Speckled means, spotty type of calcification. And how I know that is a calcification in plain X-ray, how it looks?
A bit of
Whitish.
whitish.
Whitish
Whitish.
area. Opacification.
Very good. White opacification. It looks very whitish. If I compare to the bone, it is even, brighter than the bone actually. Okay. And in the liver area, it is very easily detectable because there is no bone shadow there. Another is CT scan. CT scan may be necessary in selected cases. If ultrasound is not that, informative, then definitely CT scan can be done. And prior to the surgery, CT scan is always done. ERCP, okay, if there is obstructive jaundice, we can go for this just to make sure where is the obstruction and things like that. A wide sphincterotomy should be given so as to allow free drainage of the hydatid contents into the duodenum in this type of cases. Okay. Now, there is a chance of allergic reaction, but this is also a type of therapeutic way. We can handle that allergic reaction if it occurs, right there. Now, how do you treat anaphylactic shock or anaphylactic reaction? Let me ask this question. Yes, if it occurs, how to treat?
But sir, we will start from the resuscitation and epinephrine injection.
Good.
Sir, basically, sir, we will do resuscitation. Sir, we can give the antihistamine, and sir, that also IV. And sir, we
Epinephrine
can
is
also
a
give some
drug of choice, sir.
like albuterol. And sir, epinephrine is very important as well, sir.
Adrenaline to reduce your allergic response, oxygen,
Good.
IV,
Good.
antihistamines, beta agonist.
Good. So see that the answers are coming. Okay, I just want to know whether you have gone through this topic or not. Very good. Okay, most of the points are there. First, this is a case of anaphylactic shock. So resuscitation is really necessary. Resuscitation. We should give a lot of IV fluids to the patient. At the same time, drug of choice is adrenaline here. Adrenaline or epinephrine injection is given. Okay, antihistamines, even corticosteroids are used. And please make sure the airway is secure. Sometimes there is laryngeal edema, there is airway edema in this type of cases. So airway maintenance is paramount importance in this type of emergency situation. So what I'm saying here, during the treatment, somehow if the anaphylactic reaction occur, you should know how to handle it. If you know how to handle it, then you are not that afraid of the situation. A doctor, a good doctor or a good surgeon, okay, if they know how to handle the complication, they will never be nervous when they are treating the patient. On the other hand, if they are afraid, if something wrong happens, then how I am going to handle this case? If that type of thinking comes to you, then you are really nervous during the treatment, and then complication will happen. So the doctor should know how to handle the complication. Now let's move on. Another test or another investigation we can do is, see this, Cassoni's intradermal test. This Cassoni's intradermal test is about injecting some antigen into the skin and checking for the reaction. But the sensitivity and specificity of this test is low, and it is no longer used these days. So it is just a theoretical importance. I can compare this test with a Mantoux test, which is done for tuberculosis, and lepromine test, which I do for leprosy, a similar type of test. ELISA and immunoelectrophoresis may point towards the diagnosis, and they are detecting antibody against the Echinococcus granulosus antigen. Let's move on. Now, look at this, CT scan here. Here is the cyst. Okay, this is a cyst, hydatid cyst of the liver. This is in the left lobe of the liver. I can clearly, distinguish. This is a big right lobe. Okay, here is the left lobe, and this is a cyst which has multiple septa. Look at this septa. I can clearly identify. So this is multiloculated cyst. Now this is another CT scan which is showing hydatid cyst here. Okay, it's a big massive cyst here. This whole area is cyst. See this? This is even the better picture. This is cyst here. This. It also has multiple loculi. I can see the septation there. Now, what about the treatment? What treatment we provide to the patient? Conservative treatment and other types of treatment. Like conservative treatment, the calcified cysts are dead cysts, so they are left alone. So if the calcification is complete when we do the investigation, they are usually dead cysts, so they do not cause further problem, so they are just left alone. Another way of conservative management is symptomless. Small hydatid cyst can be left alone, and once symptomatic, or if the size is more than 5 centimeter, they may be treated. Okay, so one of the way is just leave the patient like that and do the constant follow-up, or call the patient time and again and examine with the help of ultrasound, measure that cyst size and ask for the symptoms. If any, go for the further management. Otherwise, just keep the patient under follow-up. Now, what are the medical management here? Albendazole, okay, is a drug which we use very commonly. This albendazole is given for 21 days, followed by drug holiday for 2 weeks. Means we don't give any medicine for 2 weeks, and then if the treatment is incomplete or things like that, if no improvement, okay, then we repeat the same cycle again for another 21 days. Again, there is no drug given for 2 weeks. Again, if still something is left behind, if we think like that, then another cycle is given. Means maximum 3 such cycles can be given. Okay, and there is a high chance of cure. Now, what are the indications of medical and surgical management? Let's talk about it. Now, indications of medical management would be disseminated hydatid cyst. Okay, it is disseminated there. It is spread, in that area. If it is inaccessible for surgery, like it is very deep-seated, if it is multiple, and if it is recurrent. Recurrent is difficult for surgery. How many times you go for surgery, isn't it? Surgery is a difficult one. If patients are unfit for surgery. Now, what do you mean by that? Which patients are unfit for surgery? Yes?
Immunocompromised.
Immunocompromised patient aren't fit for surgery.
Immunocompromised patient.
Good. One is
Diabetic
one is
Diabetic
diabetes.
patient.
Old patient. Old patient.
or
Very good. So see that many answers are coming. Excellent. One, the patient who is severely immunocompromised, the patient who is diabetic, but diabetes, if it is well controlled diabetes, they can go for surgery. If it is uncontrolled type of diabetes, first we need to control that blood sugar level, then take the patient for surgery. It can be done in diabetes, but we should control the blood sugar level. Very old age, you do not take this patient for surgery. COPD patient, okay, they are quite unfit for surgery. Uncontrolled type of bronchial asthma, heart failure cases. So there are so many examples. Severe, debilitating illness, very chronic disorders, they are not fit for surgery. So they are rather treated by medical management. If there is contamination of peritoneal cavity, at surgery, of course, it will be handled by a medical treatment after the surgeon tried to, wash the peritoneal cavity. Still, medical management is necessary just to kill the remaining, Echinococcus granulosus organism. Now, regarding the indication of surgical treatment, if the cyst is symptomatic, if there are pressure symptom, or if the cyst is big size, like more than 5 centimeter, an active cyst, that means is a non-calcified cyst, and if the cyst somehow is an infected one, there is no other way than surgery. Now, what surgery they are going to do? This is a bit of interesting. That's why I've included some of the points here. So please pay attention. The surgery is done by laparotomy, means opening of the abdominal cavity or peritoneal cavity. Okay, isolate the cyst from peritoneal cavity by pack dipped in hypochlorite solution. This is a very important, step of the surgery, because these packs, they don't allow the fluid to leak into the peritoneal cavity. Okay, they don't allow the fluid to be leaked. Otherwise, accidentally, if there is a leakage of the fluid to the peritoneal cavity, there may be fatal reaction. Aspirate the contents and inject scolicidal agent such as sablon or hypertonic saline into the cyst first. Try to kill, those scoliosis of Echinococcus granulosus, and then when you are sure that has happened, then remove the cyst. Okay, that is the way. So first aspirate the contents, whatever is there, and inject the scolicidal agent. Then you go for proper surgery. Now inside the cyst, peel off the laminated membrane by using sponge holding forceps. You are trying to remove the layers of the cyst now. Okay. This is the proper surgery. An attempt to remove the adventitial layer may result in bleeding, so it need not to be removed. That's what I told earlier. There are 3 layers of the hydatid cyst. The outermost layer is called adventitial layer, okay, or the pericyst. That need not to be removed because that layer is formed by the liver itself, okay, and it is very tightly adherent to the surface of the liver. So it need not to be removed. If you try, it may result in severe bleeding. But the middle layer, okay, and the endocyst, the middle layer is called laminated membrane, and the endocyst or the germinal epithelium has to be removed. Without that, the surgery is incomplete. Perfect hemostasis must be achieved, means stoppage of the bleeding should be done. Any leakage of the bile to be sutured. Post-operative significant bile leakage managed by ERCP stenting. Means stent can be kept there. Okay, stenting will divert the bile from that area to the main biliary duct. That can be done by ERCP setting. Now we have discussed about the surgery. So what are the precautions, okay, we do before this surgery? Now, see there, albendazole should be given before surgery. This is the important medical treatment. So we should start it already. Avoid spillage into the peritoneal cavity to avoid peritoneal hydatid. Many times I've explained this point in today's class. Surgeon has to be really vigilant when they are doing the surgery. They should be really careful so not to do this. Otherwise, unknowingly, if this has happened, then later on, hydatid cyst may develop into the peritoneal cavity. And if a larger amount of hydatid fluid is spilled, then anaphylactic shock may develop during that time. Injection hydrocortisone 100 milligram IV before, during, and after surgery is given to avoid anaphylactic shock. Okay, what is hydrocortisone? What type of drug is it?
Steroid.
Steroid.
Exactly. Okay, it is a steroid, so or glucocorticoid you can say, and this is given to tackle this anaphylactic shock which is going to happen during the surgery. So even antihistamines can be used, but antihistamines are used rather for the treatment purpose than for the prophylactic one. So these are the important precautions. Now there is one way, rather than the surgery, that is known as percutaneous drainage of the hydatid cyst or hydatid fluid. It is done after taking all necessary precaution, or if all necessary equipment are there, and you should have all the emergency drug with you. Okay, and I have to call the radiologist, and I should do that under radiological guidance like CT guidance or ultrasound guidance. What is the meaning here? If something happened during this procedure, like anaphylactic shock, I should know how to resuscitate the patient. I should have all the emergency medicines there, like adrenaline should be there, IV fluid should be there, hydrocortisone should be there, antihistamine should be there. Okay, the urotracheal tube should be there. So this is very important. It is also called, pair procedure. Okay, this is the short form for this, steps. P stands for puncture, A stands for aspiration, I stands for injection, and R stands for reaspiration. This is, the way of percutaneous drainage, and this can be done by the experienced surgeon.